Welcome to our channel. Today we are navigating a topic that affects millions, yet remains shrouded in uncomfortable silence: the intersection of chronic medication and sexual health. It is an intricate balance, because the very drugs prescribed to save our lives or improve our mental stability often come with a significant, unspoken cost to our intimacy. We are joined by Dr. Sterling, a specialist in sexual medicine and pharmacology, to dissect exactly why this happens biologically. Dr. Sterling, thank you for joining us. To start, how prevalent is this issue, and why do patients often feel like they have to choose between their general health and their sexual vitality?
It is a pleasure to be here. To answer your question, it is incredibly prevalent. In clinical practice, we estimate that nearly a third of sexual dysfunction cases are actually iatrogenic, meaning they are caused by medical treatment itself. Patients often feel trapped because they view these side effects as the inevitable price of admission for treating depression, hypertension, or hormonal imbalances. But biologically, it is not a binary choice. Understanding the mechanism, whether it is a vascular restriction or a neurotransmitter blockade, is the first step. When we understand that these drugs are essentially remodeling the biochemical pathways required for arousal, we can start to find workarounds that do not compromise the primary treatment.
That is a fascinating perspective, treating the side effect as a biochemical puzzle rather than a life sentence. Let's dive straight into one of the most common categories: mental health medication. Antidepressants, specifically SSRIs and SNRIs, are notorious for this. Patients often report a complete loss of libido or an inability to reach climax. What is happening at the synaptic level? We know these drugs target serotonin to help with mood, so why does that specifically target our sexual response systems with such intensity?
Exactly. And to understand this, we have to look at the relationship between serotonin and dopamine. I often describe this to my patients as a biochemical seesaw. In the brain's limbic system, serotonin inhibits sexual desire, while dopamine promotes it. SSRIs work by blocking the reuptake of serotonin, keeping more of it available in a synapse to stabilize mood. However, this chronic elevation of serotonin dampens the firing of dopamine pathways in the mesolimbic reward system. Essentially, by turning down the volume on anxiety and depression, we are inadvertently muting the dopamine signaling required for anticipation, desire, and the physiological cascade of arousal.
Furthermore, it is not just about desire, it is about the physical mechanics of sensation. Serotonin receptors, specifically the 5-HT2 receptors, are found not just in the brain, but along the spinal cord, where they regulate genital reflexes. When these receptors are overstimulated by the medication, they can delay or even completely inhibit the spinal reflex required for orgasm. This is why patients report anorgasmia, or delayed ejaculation. It isn't that the anatomy has failed. It is that the chemical signal traveling down the spinal cord is hitting a serotonin-induced roadblock, preventing the signal from completing its loop.
That explains the physical disconnect so many people describe. It is literally a signal block in the spine. Let's shift gears to another massive category: cardiovascular health. High blood pressure medications are a staple in modern medicine, yet they are frequently cited as a cause for erectile dysfunction and reduced responsiveness in women. Since these drugs are designed to help blood flow by lowering pressure, it seems counterintuitive that they would hinder a process that relies on blood flow. What is the contradiction there?
That is a great point, and it highlights a critical misunderstanding of hemodynamics. While lowering systemic blood pressure is good for the heart, sexual arousal requires a very localized, high-pressure event. Let's look at beta blockers. These work by blocking the effects of epinephrine, adrenaline, so your heart beats slower and with less force. However, the sympathetic nervous system, which utilizes adrenaline, plays a complex role in the initial phases of arousal. By systemic dampening of the sympathetic tone, we reduce the cardiac output necessary to push blood rapidly into the peripheral vessels during the moments of high demand, like sexual activity.
Then we have the issue of diuretics, or water pills. These lower blood pressure by reducing fluid volume in the body. While effective for hypertension, this reduction in overall blood volume decreases the hydrostatic pressure available to fill the erectile tissues, and this applies to both clitoral and penile anatomy. Furthermore, certain diuretics, like thiazides, can deplete zinc levels. Zinc is a crucial cofactor for testosterone production. So you have a double hit, a hydraulic issue caused by lower blood volume and a hormonal issue caused by micronutrient depletion, both conspiring to reduce sexual function.
It is incredible how interconnected these systems are. Kidney function, blood volume, and hormone production, all tying back to intimacy. Speaking of hormones, let's discuss hormonal birth control and other hormonal treatments. Many women report a significant drop in libido after starting the pill, which is ironic considering its purpose is often to enable sexual freedom. I have heard the term SHBG thrown around in this context. Could you explain what that is and why it matters to our listeners?
Absolutely. SHBG stands for sex hormone binding globulin. Think of it as a protein sponge that floats in your bloodstream. Its job is to bind to sex hormones, specifically testosterone, and carry them around the body. However, when testosterone is bound to SHBG, it is biologically inactive. It cannot bind to receptors to stimulate libido. Oral contraceptives, particularly those containing estrogen, stimulate the liver to produce massive amounts of SHBG. This sponge then soaks up the small but vital amount of free testosterone women naturally have, leaving very little available to fuel sexual desire.
So, essentially, the medication is locking away the fuel required for the sexual engine. Now, this isn't just an issue for women. Men taking medications for hair loss, like finasteride, or for prostate health, often face similar struggles. These drugs are technically classified as anti-androgens. How do they reshape the hormonal landscape, and is the effect reversible? It seems terrifying to take a medication for a cosmetic or preventative reason and lose such a core part of your function.
It is a valid fear. These medications work by inhibiting an enzyme called 5-alpha reductase. This enzyme is responsible for converting testosterone into dihydrotestosterone, DHT. DHT is potent and contributes to hair loss and prostate growth, so blocking it helps those conditions. However, DHT is also a potent driver of libido and erectile integrity. Furthermore, we are learning that 5-alpha reductase is also involved in creating neurosteroids in the brain that regulate mood and cognitive sexual processing. When you block this enzyme, you aren't just affecting the scalp or prostate, you are altering the neurochemistry of desire, sometimes leading to persistent side effects.
Now, this is where it gets complex. We have discussed neurotransmitters, blood pressure, and hormones, but there is a specific molecule that seems to be the holy grail of the physical mechanism of arousal, nitric oxide. I know this is the pathway that drugs like Viagra target, but how do chronic daily medications disrupt this specific pathway? Is it that the body forgets how to produce it, or is the production machinery getting clogged up?
It is less about forgetting and more about oxidative stress. Nitric oxide, or NO, is a gas produced by the endothelial cells lining your blood vessels. It tells the smooth muscle to relax, allowing blood to rush in. Chronic conditions like diabetes or hypertension damage these endothelial cells. Some medications, specifically non-selective beta blockers, can actually inhibit the release of NO. Without that chemical key, the smooth muscle remains tight and constricted, regardless of how much mental arousal you feel. The brain sends the signal, but the vasculature simply cannot respond because the chemical mediator is missing.
This paints a very clear, albeit concerning picture of the landscape. But we promised our listeners solutions, not just problems. Many people listening might be thinking, well, I can't just stop taking my heart medication or my antidepressant. And they are right. So what are the clinical strategies? Let's talk about medication holidays. Is this a viable strategy, or does it carry too much risk of withdrawal or relapse?
Great question. A medication holiday involves skipping a dose or two in anticipation of sexual activity, usually on a weekend. This can be effective for drugs with a short half-life, like certain SSRIs, paroxetine or sertraline. By letting the blood levels dip slightly, some patients recover enough sensation to function. However, this is risky. It can lead to discontinuation syndrome, causing dizziness or mood crashes. It is absolutely not an option for blood pressure meds or antipsychotics, where consistency is life-saving. It requires a very strict plan monitored by a physician, not a DIY approach.
A more sustainable approach is often switching classes or adding adjunctive therapy. For depression, adding a medication like bupropion, which acts on dopamine and norepinephrine rather than serotonin, can sometimes counteract the sexual side effects of an SSRI. It essentially boosts the dopamine signal to compete with the serotonin dampening. For hypertensive patients, switching from a beta blocker to an ACE inhibitor or an angiotensin receptor blocker, ARB, can often preserve sexual function because these drugs have a much more neutral effect on peripheral vasodilation and adrenaline receptors.
That is encouraging. There are chemical countermoves we can make. But getting to that point requires a conversation that many patients are terrified to have. Many feel that bringing up sexual dysfunction makes them seem ungrateful for the treatment that is saving their life. How should a patient initiate this conversation with their GP or specialist to ensure they are heard and not just dismissed?
You have to be direct, and you have to quantify it. Doctors respond to data. Instead of saying it's not working, say, my libido has dropped 80% since starting this drug 3 months ago, or I am experiencing total anorgasmia. This frames it as a specific, measurable side effect rather than a general complaint. Also, remember that sexual health is a barometer for overall vascular and neurological health. If your medication is crushing your erectile function, it might be a sign that your vascular system is under stress. Framing it as a quality of life and general health issue helps break that stigma.
That is powerful advice. Quantify the data and frame it as a health metric. Dr. Sterling, this has been an incredibly illuminating deep dive into the pharmacology of intimacy. Thank you for shedding light on these mechanisms and, more importantly, the pathways out of the darkness. To our listeners, remember, your sexual health is an integral part of your humanity, not a disposable luxury. Do not settle for silence. Thank you for watching, and we will see you in the next episode.